Good evening, everybody. So today I'm going to speak about study design. So this is the first class for you with me about study design, and I hope that you saw the previous videos. Did you see the videos, Nadine?
Oh.
Okay. So these are the videos. So this is the since 2014 biomedical research study design, and I think this is an English version, and this is mixed English and Arabic version. And this is the third one. I think you didn't see the third one, Nadine. This is ABC for semester 3. And I am very proud that students in semester 3 understood nowadays was meant by evidence-based medicine. They harvested 100 marks, 100%. So this means that they digested everything. I hope that you will find all the materials interesting because I have the major aim of this course is to establish this concept. What is this? Medicine, we should believe in this statement because this is very crucial for us to have flexible mind, to be broad-minded, to always search for gaps and questions. Medicine is not a fixed dogma. Medicine is always changing from day to day. And I think all of us are living today COVID-19 era, and every day we have new, and we use the medicine and then was proven to be ineffective. This is why we need research. So if we believe that medicine is a science of uncertainty and an art of probability, we will acquire flexible mind. And to believe that there are many gaps, even in every treatment, diagnostic approaches, we have a lot of gaps. What's meant by gap? This means that we have question that has no answer. To answer the question, we should build our mind for reading and to prepare ourselves for doing research. I'm going to start with this poll. Do you see the poll?
It has not loaded yet.
Yes, this is launching. You see now?
Mm-hmm.
So I think this is not the targeted poll, but it's okay. Let me just to select the another poll. Okay, we can start with this poll. Do you see this poll?
Mm-hmm.
We have 200 cases of steroid-resistant nephrotic syndrome who were treated with cyclosporin for the last year. So they were steroid resistant, and we shifted to cyclosporin as the line of therapy. And then after a year, we want to know, is cyclosporin effective? Who responded? And what are the side effects of this drug? If this is this study design, is it observational or interventional? Please vote. And the second scenario, cancer bladder at urology and nephro center is treated with radical cystectomy and ileal new bladder. This is the technique of surgery. And then we want to know the 5-year survival after doing 100 cases. Is it observational or interventional? Please vote. So 30 seconds, and I'm going to stop the vote. Still, we are waiting 6 students to vote. Okay, I'm going to stop the vote here. So this is, so the answer is here. The majority selected observational study design. Okay. So this is the results. Do you see the results?
Yes.
Okay. So here, it all in the first case scenario, it is almost 50% or 45% interventional and 55% observational. And in the last statement, the majority selected observational. Okay. 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 I have another poll. Just start and where's the poll? Okay. So in the second, I'm not going to just to bother you by poll and to wait the answer of the poll, but here there is a question. I want an interaction. If I ask you that medicine is based on research, if we have many specialties like cancer, cardiology, gastroenterology, infection, and nephrology, which one of these specialties has the least possible quantity of clinical trials? Which? Can you answer, Nadine?
ممكن حضرتك تقول بس السبيشالتيز
the least research. Which specialty has the least research? Cardiology, infection. If anybody else wants to answer, yes, please.
أنا ما سمعتش السبيشالتيز بس أنا بسأل حضرتك على السبيشالتيز.
You have cardiology, chest, infection, neurological, and nephrology.
I would say neurology.
Why neurology? You don't like You don't like neurology?
I don't know. It seems like it has so many chronic diseases.
Okay, I want to hear from. Okay, I want to hear from other students, please. Who wants to answer? Please raise your hand. Sarah Al-Bayoumi. Sarah?
Yes, doctor.
Which specialty is of low number of clinical trials? Is it cardiology, neurology, as Nadine mentioned, chest, infection, or nephrology?
Yani, I can't tell which one exactly, but the first...
No, just funny. It's funny.
يعني the first thing that I thought of was cardiology. I guess يعني مش عارف.
The least. Okay. So you didn't select nephrology because I'm a nephrologist, I know. But look at the answer. Look at the answer. Do you see the answer now? This is the nervous system and the cardiology at the top of the number of randomized clinical trials run through the years. So I'm going to just enlarge this to see the color. Where is the nephrology? Nephrology in the bottom. So we have two color, kidney expanded, which is the red circle, means dialysis and transplantation. And the squares, blue squares, means nephrology. So nephrology is in the bottom of research. And this is why we are in urgent need for research. Do you know why? We don't have good clinical trials in nephrology?
Why?
So I'm going to leave the answer of this question to, it seems, in the next session, because I'd like to discuss with you what's meant by endpoints. Because if we wanted to prove that intervention is very effective to reduce renal failure, we should wait for a long time, and it is very, very bad to us to wait long time to know the intervention, is it working or not? Because the best is to use solid outcome. What is the solid outcome used in nephrology is renal failure and the need of dialysis or transplantation. So it will take long time. And so the treatment in nephrology is based on a low level of evidence-based medicine in general. Cardiology and neurology are on the top.
I'm surprised to know that the choices يعني I choose cardiology and I didn't choose neurology, and it's at the top.
The top of the list. Cardiology branch is very active branch. Cardiologists all over the world worked a lot, and they have a good mind, and they did research for in clinical trials in cardiology. A lot of many thousands of patients are included. So as you see here, neurology and the cardiovascular medicines are on the top of doing research, and this is the data of number of randomized controlled trial from the 60s up to this moment. So it is a very long journey proving that nephrology in the bottom list of the research. Before discussing observational studies and interventional studies, I would like to stop here at the Confucius statement when he mentioned learning without thinking is useless. What's your imagine? If we think without learning, learning without thinking is useless. If I say thinking without learning, it will be. Anybody want to answer to complete the statement? توكا الكاشف.
Yes, doctor.
Yes. If I say to you, learning without thinking is useless, and then I asked you to complete, if I use thinking without learning, is it good or bad?
It's not efficient, I believe. No, you cannot think without learning enough.
So if learning without thinking is useless, what's your expectation regarding thinking without learning? It will be dangerous, as stated by this Confucius. Confucius is an old Chinese, and he is the father of wisdom in medicine and in everything. So before indulgement in any research, we should learn. We should stay in the past. They stated to stay in library for 2 weeks. It's better than to do research and after doing the research with the money and the time, you find it is useless, and it was addressed before. So before putting a question of research, we should learn. Learning and then thinking, both of them are complementary, but it's better to start with learning and then to think and to put questions.
Yes.
So what are the types of study designs in medicine research? If you hear to the videos, the answer is clear. We have 3 major types of designs, either observational one or interventional one. And the second name, the synonymous of interventional is experimental, the same. So when I say interventional, like I'm speaking about experimental, both of them carry the same meaning. When I was a medical student, I imagined that experimental, it should mean animal study or experimental animal models. But as I'm going to explain to you, the different types of interventional, we have animal, and we have many types of human interventional study design. Then the third type, it is not really a research done on human beings, but it is a collection of the previously mentioned and reported studies. So here we don't work on patients, but we are work on publications. So we collect papers and then collect and combine the results in a blender. Do you know what's meant by blender? Nadine?
No.
What's meant by blender?
It's like a machine that puts everything together.
In Arabic, khalat. So we mix all the results together, trying to reach a good statement, a good answer. Because if we depend upon a small study, it will carry low level of evidence, as I'm going to explain later. So these are the major 3 types of study design: observational, interventional, and meta-analysis. Let us just enumerate the observational designs, and then I'm going to explain the poll results that you just shared. So observational include case report and series. If it is only one case, it is a case report. If we have multiple cases, it is case series design. Descriptive. Then we have analytical designs. In the analytical designs, we have comparison. So this is case control, cross-sectional, cohort by its 2 types, typical and atypical design. So this slide summarizes or enumerates the different types of observational design. But the question is, you want to say observational and you want to say interventional. If you remember the poll that I'm going to share the results of the poll again. This is the, do you see the poll?
Yeah.
Do you see the poll again?
Yes.
Okay, regarding the first one, 200 cases of steroid-resistant nephrotic syndrome who were treated with cyclosporine for the last year. And then we wanted to know who responded and who have side effects. If this is a design, is it observational? As here, 16 of the students selected observational, or it is interventional as selected by 13? The answer here, we use drugs. Yes or no?
Yes.
Yes, we use drugs. But to say interventional, it is not enough that we use the drug. And we should ask ourselves, do we use drugs because this is a line of treatment? Or we use drugs after asking the patients to consent to participate in a research? What was our intention when we started cyclosporine for these patients? Was it because of research, or this is the second line of treatment? Is it?
As a line of treatment.
A line of treatment. So this is a line of treatment and not a question to be answered by research. So long as the intention is not to do research, it is observational study, even if we use the drugs. And the second example, it is cancer bladder and doing operations, radical cystectomy. It is surgery, operation, intervention. Yes, it is operation. It is surgery, major surgery, but the study design is not interventional. It is observational. Why? Because this surgery here was done at the line of treatment, and the patients didn't consent to participate in a randomized or a clinical trial. Do you know now what's meant by observational? So observational, before discussing observational, I would like to start the journey with case report. Case report means that we have funny case that carries a very attractive and interesting messages, either in diagnosis or treatment. Because it is not common cases, then the doctors or researchers wrote it in a case and it is published in a journal. And after its publication, it became case report. So if just an example of case report, although, as I'm going to mention in the evidence-based medicine, case report lies in the bottom of evidence-based medicine. It is the lowest level of evidence-based medicine, but it is very nice, and it usually stimulates our mind. So this is a case, a 74-year-old male renal transplant patient. So this is a patient who has renal failure and was treated with renal transplantation. And after kidney transplantation, because in kidney transplantation, the patient was maintained by immune suppressive drugs, and the price is some few patients may develop malignancy. This patient was unlucky because he developed the lung cancer, non-small cell lung cancer. And nowadays there is an immunotherapy or checkpoint inhibitor. So this is a drug used to treat non-small lung cancer or melanoma. The drug is known as nivolumab. After treating the patient with nivolumab, what happened? The patient suffers from unexplained acute allograft dysfunction, acute allograft failure, renal failure of transplanted kidney, because serum creatinine increased from 0.7 to 7.5 milligram per deciliter. Here I have a question, and I think you saw the video. Nadine, what is this? Is it interesting case, Nadine?
Yes, because there's an allograft rejection.
So this is a very interesting case because this is nivolumab. It is a relatively new treatment modality for devastating or bad cancer. But here, the patient is complicated by acute renal failure of transplanted kidney. So we need to know what is this complication? Is this complication related directly to the drug treatment or not? To know this, I like to just to show you, it is not necessarily for you to know the details of the immunotherapy, but to know the idea. If this is cancer, and cancer can release ligand that can be presented by antigen presenting cells to the patient T lymphocytes. We have here ligand from the cancer, known as PDL1, programmed death ligand 1. It will bind program death 1 on the T lymphocyte of the patient. From its name, it is programmed death 1. So a programmed death 1 bound to its ligand, the T lymphocyte from the name will be exhausted because it is programmed death. It is inhibitory pathway. So T lymphocyte of the patient is inhibited. What will happen if the T lymphocyte is inhibited? Cancer will grow. To normalize the environment, to allow lymphocyte to attack cancer and to eat cancer, we want to stimulate the T lymphocyte. How to stimulate lymphocyte is by interfering with this pathway, either sorry, by using drugs that bind the programmed death 1, which like nivolumab, which is used in this case, or to stop the ligand from binding to its corresponding programmed death 1. If we stop PD ligand 1 binding, then the T lymphocyte will be released from exhaustion and it becomes activated. And when the T lymphocyte is activated, it will eat cancer. So this is the rationale of immunotherapy. I'm not going to mention other details in this slide, but it is enough for you to know the rationale of using this drug to treat cancer. Now what happened? What is the price of immune stimulation? It is, here we have a kidney transplant and we want the immune system to be suppressed. But if we stimulate immunity, this may be associated with acute renal rejection, severe rejection, and acute renal failure. Do you understand me,
Yes.
Toka? Toka.
I'm kind of lost يا دكتور يعني ما فهمتش قوي.
I can repeat it. I'm not. My aim is not to give you details about immunotherapy for cancer, but just to taste the beauty of the case report. This is a case of kidney transplant who developed the lung cancer and treated with new modalities known as nivolumab. This is monoclonal antibody that stimulates immunity. Because it stimulates immunity, it may cause problems. That was seen in this case. What is the problem? Is immune stimulation and the immune cells, T lymphocytes, attack kidney allograft, leading to acute renal failure. Do you understand now, Toka?
Yes, sort of.
Okay. So always think, again, as I mentioned in the beginning, the major discrimination between observational study design and the interventional one is the assignment of exposure and intention to intervene. If the intention at the beginning of any drug or operation is to do research, it is interventional. But if the intention is to treat the patient, because this is a line of treatment, and we take the consent of the patient as a line of therapy and not for research, it is observational study. So the most important discriminatory point between observational design and interventional is the intention of investigators. If they are starting this drug as a research, it is experimental study or intervention. If it is not, if it is starting because this is the second line of treatment or a line of therapy, it is observational study. So we should ask ourselves, if the assignment of exposure for the intention of research, if it is no, so it is observational study. Then, do we have one group or two groups? If it is only one group, it is descriptive study. So if we don't have comparison, this means that we are dealing with descriptive study. Like, I want to know if I do collect the body weight, age of all Manchester medical program, and I can express them as the following. We have 1,000 students, 500 the body weight is 60 kilogram, and so on, so on, so. Is there any comparison here?
No.
Is there any comparison? Do we have groups?
No, there isn't.
Toka, do we have groups?
No.
So this is descriptive study because we don't do any intervention. So it is observational, and we don't have groups for comparison. It is descriptive study. If we have two groups, then to know the rationale of doing observational study is to know relationship between exposure and outcome, or risk factor and outcome. And I'm going to give you examples to understand what's meant by exposure and outcome. Suppose that we have this study design. And if you look at the video, this is just a repetition. We have E. So long as we have two groups, this means that we have exposed and non-exposed groups. Are they two groups or one group? Are they one group or two groups? Muhammad Amr?
Two groups, Dr. Exposed and non-exposed.
So we have two groups, and we're starting with exposure or risk factors. One group is exposed to certain risk factor, and the other group is not exposed to this risk factors. So they are two groups. And then, if we have two groups, we should ask ourselves, are we starting with exposure, or we started at the end by looking at the outcome or the end result of the exposure? Here we are starting with exposure. So we have two groups, exposed and unexposed. And then the second point of the observational design is to know the time. Do we have one point of time or multiple points of time? If we have multiple points of time, we should ask ourselves, is it prospective? So we are looking from today to tomorrow, or it is retrospective from today to yesterday? Here, if we start with two groups, exposed and unexposed, and then we have two groups of patients who will be followed up every 1 year, for example, until 10 years to assess occurrence of certain outcome. So the time here, is it one point or multiple point? I want multiple points. And so it is longitudinal. Longitudinal means multiple point. Toward the future or toward the past?
Future.
Future. So it's prospective. So here we have two groups of patients, exposed and unexposed, and then we evaluate both groups at time intervals to end after a period of time, and then to assess the occurrence of the outcome. By the example, you will understand everything. If we select smoking as an example, so smokers and non-smokers, suppose that we have 1,000 smokers and thousands non-smokers, adult, compared to age and gender. So it's okay. We have a smoker group and non-smoker group. And every year, for 10 years, we will do X-ray chest. If we start this study today, 2020, and then we will end 2030, to know, does smoking, will smoking lead to cancer or not? So every year, we'll do chest X-ray for both groups to assess occurrence of any suspicious tumor in the chest. By 2030, we will do the analysis to see who had cancer and who has no cancer. If this is the design, I'm starting with exposure or risk factor between two groups to be assessed every time, reaching at the end of the follow-up to know to the outcome in each group. This is typical cohort study. So typical cohort study, I want to ask Nadine, what's meant by cohort? What's meant by cohort from the language point of view? Nadine?
مش عارفة بصراحة.
Cohort means group of patients, number. So cohort means a group of patients. But when I say cohort study, it is a specific design of observational study. So even if I have interventional study, I can say we have 100 cohort of 100 patients allocated in interventional study. So we shouldn't misunderstand the term cohort from the language point of view. If I say cohort without study, this means the group of patients, number of patients. Is it clear? But if I say cohort study, it is a type of observational study that we started by comparing two groups, exposed one and non-exposed one, to a certain risk factors, and trying to assess the relationship of this risk exposure to occurrence of the outcome. So the question of this research is, what will happen if we smoke? The other example, if we, for example, if we wanted to assess the heavy calorie diet, so we have two groups of persons, heavy calorie consumers and modest calorie consumers, and then we follow up every year to assess their body weight, diabetes, hypertension, etc. This is a cohort study design. I want one of the students to just to give an example of other cohort study design. انا عاوزكم تتفاعلوا كده، خليكم حلوين. ساره 60.
Yes, sir.
Yes, please. Can you give me an example like the two examples I just mentioned?
ممكن مش عارفة والله يا دكتور بصراحة.
قولي بأي لغة يعني مش مشكلة.
Oh, I think يعني it might be like ممكن like the first case اللي هي بتاعت السايكلوسبورين وكده ولا؟
ماشي، بس انت بقى انت بتقولي نفس اللي انا قلته. ناخد حد تاني. أمنية.
ممكن يا دكتور يعني مثلا الريسك فاكتور يكون الكحول مثلا، الكحول انتيك
اديني example. Give me an example.
يعني
So we have alcohol drinkers and non-alcoholics.
and non-alcohol, yes.
Alcoholics and non-alcoholics. So alcohol here is exposure. And then what is the relationship that you want to address?
الاوتكم يعني ممكن يكون مثلا يعني liver cancer مثلا.
Okay, so you have two groups. This is a design. Two groups, group of persons who are alcoholics and another group non-alcoholics. And every year, for example, we will do ultrasound. We do CT scan to know if there will be cancer pancreas or not. After 10 years, we stop the study to do statistics to know is does cancer occur more frequently in alcoholic or not. If the study design is made like this, forget the scientific material. We have alcoholic and non-alcoholic, exposed and unexposed. We have multiple points of time of evaluation, so it is prospective, and it will end after a period of time. It will end tomorrow to know the outcome. So if the study is done like this, starting with exposed and unexposed, assessing the patients, both groups in multiple point of time to know the outcome at the end of the study. This is a typical cohort study. So if I say cohort study, it is typical. If I say concurrent cohort, it is typical. So the names of the cohort study is typical cohort study, and concurrent cohort. The three names are carrying the same meaning. I want another example. Samar Abdul Hafiz. Samar? Yes, Samar.
Yeah. So you asked about an example of cohort study?
Example. Yes, please.
Like the asbestos exposure, and then we follow the patients till the development of the lung cancer.
So you have asbestos and non-asbestos. But
yes.
Okay. So it is so exposed and unexposed, and then evaluate for lung. It is cohort study. The bed bound today nowadays we are staying at home. Even we have the lesson, the class here while you are staying at home. So if we are bed bound, does bed bound will increase osteoporosis? So we have two groups. If we want to do it in a cohort study, bed bound group and the sun exposed group, and then doing a DEXA scan to diagnose osteoporosis every year. And after a couple of years, we end the study to know the correlation or relationship between staying at home, bed bound, away from sun, and occurrence of osteoporosis. All these are cohort study. If we take patients who are working in the farm, exposed to sun, and the other working away from sun, and to assess occurrence of skin cancer, then we examine both groups every now and then until the end of the study period, and then we assess who had or had not cancer. So this is typical cohort study. Don't forget that in cohort study or typical cohort study, it is prospective observational study design. There is no intention to intervene. Here I have a question to Nadine. Can we do here intervention study? If we wanted to build up relationship between asbestos and lung cancer, or smoking and lung cancer, can we do it in an intervention study?
It's a bit unethical because it's harmful.
It is
to the
unethical completely. I cannot do it. Why? Because I cannot say, Nadine, please smoke for me. Do you agree to smoke? Yes, I agree. It is impossible to ask you because smoking is known to be harmful. So sometimes it is impossible to carry out a study to prove that smoking is associated with lung cancer or asbestos associated with interstitial lung disease, whatever the harm. So this is why observational study, although, as I'm going to mention later, it is of low level of evidence, but it is a good start. If we can apply it in intervention study, will be okay. Sometimes it is impossible, like our examples here, to be carried out in intervention study design. Okay? Let us go to, so this is the situation. We have sample of people. The sample of people are divided into two groups according to the exposure. So we have a risk factor exposed and a risk factor not exposed. And then we evaluate them every time until we reach the end of the study. So we have multiple points of evaluation to end with the occurrence of the outcome, and then we can build the relationship between exposure and outcome. Am I clear?
Yes.
Okay, let us go to the second example of analytical observational study. What's meant by analytical observational study? We have comparison groups. Here, what is this? This is the outcome. We have hepatoma, hepatocellular carcinoma group of patients. And then we want to build up the relationship of exposure, for example, to aflatoxin, alcohol, hepatitis C, and hepatocellular carcinoma. And then, so long as we have a group of the outcome, we should have a matched group in age and gender without this outcome. So to run it or to have it in observational study, in analytical, we should have two groups. But here, I'm not starting with the exposure like the cohort study. I'm starting with the disease or the outcome. So it is case. And we have control group without the disease. So it is, and then the time is multiple point of time. I review the files of the patients regarding the past exposure to certain exposure to know who is exposed, the percentage of exposure in the disease or the outcome group, and the percentage of exposure in the control group. If the study is run like this, starting with the outcome and ends with the exposure, and the time is toward the past, it is case control study. So case control study is the second type of analytical observational study where we have two groups of patients. We compare the patients who have certain disease or certain outcome to another matched group without this outcome. And both groups were searched, were evaluated, were examined, their files were reviewed to put our hands on the exposure during this journey to in the past. So it is retrospective case control study. I want examples here. I want to hear from you. Please be free to interact. Omnia Mustafa. Omnia. Okay, Omnia. Omnia عز الدين. Omnia.
Yes, Doctor.
Yes. Can you give me an example of case control study?
Maybe مثلا two groups of diabetic patients.
أيوة.
And يعني experience post for Ramadan fasting.
But you should, and I want you just to think of your statements. If we say two diabetic groups, so where is the control? Both of them have the disease. And I mentioned we should have, if you wanted to carry this example, you will say we have diabetic and non-diabetic group. And then we evaluate their files through 10 years back to know who eat much, who is exposed to certain risk factors, to certain behavior. So by this way, it is case control study. Case control, why? Because you started with a group with certain disease and the other group without this disease, okay? If we fix the example of smoking and lung cancer, because here we mentioned the smokers and non-smokers, and then they will be followed up for years until we know the outcome. If we take it here, then we should have a group of lung cancer and a group without lung cancer. And then we reviewed their files regarding smoking. So it is multiple point of time toward the past history. So it is today and yesterday, and this is the case control study. I want another example. Muhammad Amr.
ممكن يا دكتور يعني لو
Imagine any example. Any.
يعني any disease, the relation between, for example, as you said, لو مسكنا اللي هو sun exposure والskin cancer مثلا، احنا نجيب two groups, one with the skin cancer and the other group without skin cancer.
Okay, so it's okay. So long as you start with the disease, but be aware that when we say we start with the disease, we know that the patient had the disease. We don't do investigation to know the disease. As like what I'm going to the chest clinic and asking the resident, where are the files of patients with lung cancer? These are the files, okay. Then we search for the control with persons without lung cancer. So the starting point, the outcome is known, either to have it or not. So we have, if we put it in a cartoon, like the cohort study, I'm going to just magnify, we have disease group, not diseased group. Here the time is backward, flashback toward the past, to know, to assess the exposure, yes or no. And then to do statistics, suppose that this group of diseased persons, if we have here 100 and we here 100, and then after this journey in the past, we find 50 are exposed, and here 1 is exposed. Here's 1% and here 50% exposed. This 50% in comparison to 1%, it is highly significant association between exposure and the occurrence of the outcome that we have. Is it clear now? Clear?
Yes.
Let us go to the third one. What is this? Nadine, can you comment about this?
This is like we're measuring the outcome and the exposure at the same time.
So the time here is 1 point of time.
Mm-hmm.
The time is 1 point of time. This means that we don't have follow-up either toward the future or toward the past.
Mm-hmm.
Okay? So it is today, this point of time. If the study design is like this, it is known as cross-sectional study or snapshot study, survey study, all these prevalence studies, all these are model of cross-sectional study or observational study with single point of time assessment. So for example, any prevalence studies, if I want to know the prevalence of diabetes among the Kahliya governorate, so I expose all the Kahliya governorate to examine them for the plasma for glucose. So it is prevalence. So by the test will discriminate the Kahliya population into diabetic and non-diabetic. So all prevalence studies are cross-sectional study. So if you have an MCQ question saying the prevalence study assess the prevalence of whatever, it is cross-sectional study because there is no longitudinal follow-up, either toward the future or toward the past time. Is it clear?
Yes.
We have a good study here. We published a study in a cross-sectional study. The correlation of left ventricular hypertrophy among kidney transplant recipients with their demographics. What we did in this study, we did echocardiogram for all renal transplant patients. And then we correlate hypertrophy. So by echocardiogram, the echocardiogram divided transplanted patient into hypertrophy group, left ventricular hypertrophy group, and non-hypertrophy group. And then we can know the age, body weight, because it needs no time. So, and we correlate this with the drugs they are receiving at the same moment. So there is no longitudinal follow-up. And then we can correlate all these with left ventricular hypertrophy. The time here is 1 point of time. And you have a test that make the whole group into 2 groups, hypertrophy group and non-hypertrophy group. Is it clear? So just to review, if we don't assign the exposure, we don't intend to do research from the beginning, we are dealing with observational study. If we don't have comparison group, this means that we are, it's just descriptive data. We have 2,000 persons, 20 diabetic, 20 hypertensive, 50 had cancers. So it's just a description and no comparison. If we have comparison, we should ask ourselves 2 questions. What is the relationship between exposure and occurrence of disease or outcome? And what about the time in the design? Is it 1 point or multiple point of time? If I'm going to assess relationship between exposure and outcome, disease and risk factor, in one group, in the whole group of patients without longitudinal follow-up, so it is cross-sectional study. So the question here, what is happening? And if we start with the disease and comparing diseased group to control group, and then longitudinal evaluate their files multiple times to the past, it is case control study. And the question, what will happen? What happened? Sorry, what happened? And if I start with exposure and then assess 2 groups, exposed and unexposed, to the future, so I'm going to answer a question, what will happen? So this is cohort study, this is a case control study, and this is cross-sectional study. Okay, clear? I want to ask you a question, and I want one of the students who is brave to answer. And who will answer it, there will be a gift, inshallah. So if I go to chest clinic, then I ask the resident to invite all patients in the clinic for chest X-ray. All of them are subjected to chest X-ray today. Chest X-ray revealed lung cancer in some of the patients. So chest X-ray divided them into lung cancer group and no cancer group. And then we evaluated their files for 5 or 10 years, searching for exposure. Is it case control study, yes or no? Who wants to answer? Any student wants to answer, please raise your hand. أنا مش عارف أنت كسالة ليه؟ توقع؟
Oh, it's not a case control study.
Why?
No.
Because the outcome wasn't known. احنا عملنا investigations عشان نعرف هم عندهم cancer ولا لأ.
شاطرة ممتازة يا توقع. محمد أنت do you want to say anything else? It seems that you have another. محمد عمرو.
لا ما كانش انا يا دكتور يعني.
Okay.
ما كانش انا.
So you agree with توقع؟
يعني هو انا بس في نقطه مش فاهمها. هو ما احنا عملنا الانفستيجيشن ده فطلع لنا اوت كم هو ده اللي احنا عملنا له يعني هو ده اللي احنا عملنا له اللي احنا بنعمل عليه تيستنج اكسبوجر.
عمر
كده عندنا اوت كم يعني.
اوكي ثانك يو محمد. عمر.
Yes, doctor. I think this is a typical cohort study.
يعني انت بتسبق الاحداث. اوكي. what do you mean by a retrospective cohort study?
ببتدي بالاوتكم.
So okay, thank you very much, Omar. I'm going to explain. Here in the case control study, as I mentioned in the description of case control study, we should know from the start the patient should be labeled as patient, diseased, with certain outcome. If I do investigation to know the outcome, this is not case control study. It is a retrospective cohort. So the retrospective cohort or atypical cohort or non-concurrent cohort, it is similar to case control study in its retrospective nature, but it's not like case control study. We should search for the disease. From evidence-based medicine, retrospective, although all of these studies carry low level of evidence, but if you taste a retrospective cohort is superior to case control study because we apply a test to know the disease, so the level of bias is less than if I go directly to patients who have the disease and then selecting a group to compare, a control group. So both of them are of low level of evidence, but retrospective cohort is little bit superior to case control study. So these are the types of observational studies that I like you to know. Okay? Do you have any questions here? Do you have any questions?
No, sir.
No, I don't.
Do you like to continue or to stop here?
I guess we can continue.
Excuse me?
I guess we can continue.
Okay. في حد كاتب حاجة؟ Chatting. Okay. There is no questions. I'm going to proceed. It's okay. Perfect. Okay. So this is an example of retrospective cohort study. In this retrospective cohort study, they assessed 3.5 million persons regarding the association of constipation and kidney disease. So kidney disease was not known. So all these patients were tested for kidney function and then take the history of constipation, degree of constipation. So it is a retrospective cohort. I started this presentation by nominating the design that we have in medicine. We have observational design, and we have interventional design, and we have meta-analysis. Now I'm going to shift to the interventional design. Interventional design or experimental design, the investigators from the beginning decided to do research, either on an animal or human. I'm not going to start with animal, but I like to enumerate the human interventional designs that we may have. So human interventional designs are divided according to the presence or absence of the control. So we have either controlled or non-controlled. Before I'm proceeding, when I say human interventional, this means that doctors or researchers assigned the exposures, and from the beginning they knew that this is a research, and the patients knew and agreed to participate in research. So this may be an uncontrolled interventional study. Can Nadine give me an example of non-controlled human interventional design? I can say okay.
Non-controlled meaning يعني إن هو it's not the researchers and the patients do not know that it's a trial.
Non-controlled means no comparison. So if you remember the example I mentioned in the poll regarding steroid-resistant nephrotic syndrome, patients who were treated with cyclosporin. If it is run like this, we have a cohort of patients, number of patients who were treated with steroid with no response. Then we sit with them. Dear patients, there is no response to steroid, and there is drug X that may help, but we are not sure of its efficacy. But some groups worked on it and they documented efficacy. Then the patient will ask what are the side effects, and then we answer their questions. And at the end of the dialogue, the patients decided to participate in a research, taking cyclosporin as this example. If the scenario is like this, is it interventional or observational?
Intervention.
Interventional, because I assigned the exposure for research from the beginning, and the patient agreed. Here we have 100 patients of nephrotic syndrome, steroid resistant. All the 100 patients received cyclosporin after their acceptance, after their consent. Is there any control here?
لا ما فيش comparison.
There is no comparison, no control group. So how to know that the response was to cyclosporin? To know the response is due to intervention, we should have a comparison group. We should have control group. In the absence of the control group, this will make the interventional design is in a very weak, little bit superior to observational, but it is weak because there is no comparison group. Okay? Because you may say to me, if we leave these patients for their natural history, the nephrotic state may disappear. How to swear that the drug was effective? I cannot defend your query. So the presence of control group is essential to prove the drug efficacy. And so long as we are living in COVID-19, this is a big problem, because if I say we have antiviral that may help, can we test it in controlled fashion, in proper controlled fashion? It is very difficult. If we have patients who have COVID-19 and on mechanical ventilation, here we can use the drugs without control as a compassionate use. So waiting any evidence from studies. So sometimes it is difficult to have it in controlled fashion. So if I give you an example, MCQ question, a group of patients consented to participate in the research to receive intervention X. All of them were exposed to this intervention and they are evaluated after a year. What is the type of this design? It is interventional, non-controlled human study, okay? So we may have control. According to the type of control, the human interventional designs are divided into 3 groups, big groups. Historical controlled human interventional study, sequential controlled human study, or concurrent interventional human study. I'm going just to give you examples. It is just I think when I finish this slide, I'll stop. So what's meant by historical control? Muhammad Amr.
ايوه يا دكتور.
Omar.
Based on old research.
Excuse me?
Based on old research.
Just mention it in details. How to depend on previous results? An example, here we are working at Urology and Nephrology Center and in nephrology unit, it is interested or the primary responsibility is about renal transplantation. So this is the main specialty of us, is renal transplantation. All the times we have evolution and the change in immune suppressive drugs. In the near past, we used steroid, cyclosporin, and the cerebrin as the standard protocol of immune suppressive drugs. And then, by the years, we have tacrolimus and other drugs. So we have old and new drugs. If we wanted to test the new drugs, but we don't like to wait long time, because if we say all coming transplant will be divided into two groups, or one group will receive the new one and the other will receive the old one, this means that will stay longer until we test the new immune suppressive drugs in respected study. So what we can do, we can give all the coming transplanted patients the new intervention, and then when we have a big number of patients treated with the new immune suppressive regimen, we can compare their results to the results that we have from the previous cohort on the old transplant, on the old immune suppressive regimen. Here in this study, did we compare anything? Yes, we compare, but to the historical group, a group of patients who we had in our pocket. Is it clear?
Yes.
Can you give me an example, another example?
It just works on everything.
So you can say there is a new drug to treat obesity. So we had in the past many drugs, and they were full of complications. So in the new experiment, by using the new drug, we incorporated 100 obese persons, and then they were treated with the new drug, and then we follow them regarding weight loss and occurrence of side effects, and we tabulate the results, and then compared the results of this weight loss drug, new one, to the old ones that we had. And then we say the new drug is more effective because it achieved more weight loss and with less side effects. So this is the scenario. It is so it is little bit superior to non-controlled, but again, it is not like the concurrent controlled studies. So this is historical controlled intervention. What is sequential? What's meant by sequential? Sequential means that we compare either here, as you see, self-controlled. What's meant by self-controlled? We evaluate the patient and compare his or her status before and after the intervention. For example, if we want to prove that cholecystectomy is effective in ameliorating right hypochondrial pain, then the patients will be asked to consent for cholecystectomy as a part of research. Then, before cholecystectomy, we measure pain score. Then we give the pain score, for example, the average is 7 out of 10. So 7 per 10. And then after cholecystectomy, we evaluate the pain score, and then we find it 1 per 10. This means that intervention reduced pain so much. Here, I compared the state of the patient before to the after the intervention. The same, if I wanted to assess the efficacy of certain drug to ameliorate itching or pruritus, I measure pruritus score before treatment and after treatment. So comparing the pruritus score before and after, I can know the efficacy of this drug. Another example, depression score before and depression drug So before and after, so the patient is the control of him or herself. It is self-controlled study. Is it clear?
Yes.
So the second type is crossover. What's meant by crossover? I want anyone to answer this. What's meant by crossover? Okay. طاهر زيادة. Okay.
I have two groups, 100 patients, divide them into two groups, 50 and 50. I let group A take drug X and let group B take drug Y.
Okay.
For a couple of months, then I stop the two drugs for about 2 weeks. Then reverse, make group A take drug Y.
Excellent, Tahir. Excellent. Because the crossover means that we have two phases of experiment. Two phases. The first phase, if suppose that we have group A and B of patients, and they were tested. So we have group A treated with drug A, and group B treated with drug B. So the first group is treated with A, and second group is treated with drug B. And then after the period of time, we evaluated the efficacy in each group. Then we should stop both medication for both groups. So stop A and B for group 1 and 2. For a period of time, usually we follow 5 half-life to avoid the delayed effect of the drugs. Then after 5 half-life of stopping the medication, usually in 2 weeks, then the two groups were left to their basal state. Then we reverse. The group 1 will receive drug B, and the group 2 will take drug A. This means that we make crossover. Who were treated with A will take B, and were treated with B take A. To be evaluated in another period of time to see if, for example, drug A is superior in the first phase, and then it is the same, the drug A is superior in phase B. This will give a bonus for the drug because its efficacy is continuing, is permanent, although it changed the demographics of the patients. Am I clear? An example, I mentioned in the video the antiproteinuric drugs. If we have a group of patients, 100 patients, 50 received, for example, atenolol, which is a beta blocker, and the 50 received the captopril, which is angiotensin converting enzyme inhibitors. Before giving their medications, we assess proteinuria. In the baseline, both groups have proteinuria, for example, 5 grams per day. This is the average proteinuria per patient. Then we monitor proteinuria every month in both groups after receiving the drugs. So we have atenolol and the captopril group. After 6 months, we find proteinuria to be reduced to 1 gram per day in captopril and continued around 5 grams in atenolol. This means that in phase A, captopril is superior to atenolol. Then we stop both atenolol and captopril for 2 weeks, and then the group of patients who were treated in phase A by atenolol will receive now captopril and vice versa. And before taking the medicine, we evaluate proteinuria, and we find both groups have the same degree of proteinuria, 5 grams. And repeat the experiment after making crossover of medications. At the end of the phase B, we find that captopril again is superior to atenolol. This will give a bonus for captopril. So it is crossover study because it is run in 2 phases separated by drug holidays. And after drug holidays, there is a shift between groups regarding medicines used. So if this gives a bonus in pharmacology. Why there are some defects in the crossover? Because some drugs have delayed effects. For example, bisphosphonate stayed in the bone for years. This is why we should know the pharmacology of the drugs before saying that the drugs are suitable for crossover study. Can anybody give me an example for crossover study? Another example? Dr. Firman Khan, do you understand me? Fireman or Firman? I don't know.
Thurman.
Yes.
Yes, Firman?
Yes.
Yes. Do you understand what I mentioned?
Inshallah.
Inshallah. Can you give me an example of crossover study or self-controlled study? Okay. طاهر زيادة.
ايوه دكتور.
Yes.
اكزامبل.
Yes.
ماشي، يبقى مثلا ممكن لو حد مثلا رينال ترانسبلانت مثلا
ايوه
وبياخدوا دواء معين، بعد كده اعمل ايه بقى؟ ثانية. هقسمهم مثلا 50 و50 لو هم 100.
ماشي.
وافضل اتابع مثلا مده 6 شهور، وبعد كده اقوم عاكسهم بقى، ال 50 دول ياخدوا الدواء الثاني.
Okay, so at the end of the day you understand the principle of crossover. Here okay, so the last type of human intervention is the concurrent controlled. What's meant by concurrent? This means the parallel groups. We have two parallel groups. The two parallel groups either non-randomized or randomized. What's meant by randomized, Nadine?
This is like the lowest degree of bias because I do not know about the patient. I did not select them.
What's meant by randomized? What is the
Not
value of randomization?
Decreasing the degree of bias in the study.
How, in the form of? Because the bias in a study is.
May I answer?
Excuse me. Yes. Yes. Toka?
May I answer?
Yes, please.
Randomization means that you give an equal chance for every person included in the study to be in the experimental. I'm sorry?
Perfect. So if there is an equal chance to participate in either group, this equal?
Intervention or in the control group.
Yes, so this equal that we avoid?
To avoid the known and unknown confounders.
Selection bias. Selection to avoid selection. So randomization is the way, and this is one of the MSQ questions, by the way. Randomization, it is the way to avoid selection bias. What's meant by selection bias? If I want to prove the drug A is effective and associate, for example, with better survival, then what I do, if I take money from the company to prove the experiment, so I bought all the patients with multiple comorbidities in the control group and all young generations with no comorbidities in the active group to receive the medication under assessment. If the study is run like this, by the default, all the patients will die more than the difference between the drug and the control is not because of the drug, but because of selection bias, selecting all the patients in the control group. Do you understand now?
Yes.
So to avoid selection bias, it is to be done in randomization. Okay? So the value of randomization is to avoid selection bias. I prefer to stop here because I still have very detailed information about the way of randomization and examples. And if you have any questions, I'll be happy.
So doctor, like for now, the highest level of evidence in all the studies we've learned today. So this would be the.
I'm going to mention the evidence from the study design later, but if you look, just make a microscopic view on all the study I mentioned, a randomized controlled study is the best. So randomized controlled study is a study that helped us to avoid selection bias. Number two, it is the best study to prove drug efficacy and safety. So if you have any mixed question, which is the best to prove the drug efficacy, it's a randomized controlled study. But I'm going to explain and to characterize because the study in the next session. But randomization is the best to avoid selection and is the best design in interventional human study that you may know. Okay?
Yes.
Do you have any questions or to stop here? Stop? Okay. Goodbye, and inshallah we'll arrange another meeting because I prefer this way of interaction. If I come to read the slides, you can read anything and doesn't matter. If you am I right or wrong?
Yes, you're right.
Okay, thank you very much. Hoping you the best and see you inshallah soon. Bye bye.
Thank you.